If you progress on a PARP inhibitor, are you by definition resistant and you would never reuse a PARP inhibitor again, or are there ways to overcome that resistance? 3, are there patients for whom PARP inhibitors, even though they may have BRCA mutations or other clinical biomarkers that would indicate that they might benefit, for whatever reason, they're never going to benefit? Are there tests that we can do, biomarkers that we can develop that will really help us sequence and pick for whom which therapy is the right therapy? So those questions are now. Those questions are coming now. So our patients are going to be expecting clinical trials to be available and for us to be really mobilizing our best scientists to evaluate how to maintain sensitivity to PARP inhibitors so that we can continue to provide sequenced therapies to women over their lifespan. What we know, fortunately, in the US and in Europe is that the development of active therapies in the recurrent setting has resulted in this increased prevalence of women with ovarian cancer. So even though we have no decrease in incidence and unfortunately no decrease in mortality, we have more women right now living with ovarian cancer than we've ever had in our history. And why is that? It's because they're living longer, because we do have these active sequenced therapies. Now that we're using some of our best sequenced therapies earlier on, we're really going to have to be developing these clinical trials that are going to help us identify how to triage women when they recur to the next best line of therapy. And whether that includes a PARP or whether you say, I'm never going to use a PARP, we need to have those answers. We just can't continue to be really empiric and just say, well, I'll try. That's not good enough. And we really have the science that will help us, I think, in some settings, identify patients for whom PARP is a good idea and for whom PARP is just not going to work.